Diabetes mellitus management focuses on eliminating hyperglycemia symptoms and preventing microvascular and macrovascular complications. Symptoms usually improve when plasma glucose falls below 200 milligrams per deciliter, but long-term control is the primary target. Care must be individualized and patient-centered with a multidisciplinary diabetes care team. Key team members include physicians, diabetes educators, pharmacists, nutritionists, and mental health professionals. Ongoing care includes HbA1c monitoring 2 to 4 times per year and continuous glucose monitoring where available. Lifestyle management is the foundation, including diabetes self-management education, nutrition therapy, and physical activity. Medical nutrition therapy emphasizes weight loss of 5 to 10% in type 2 diabetes and carbohydrate matching in type 1 diabetes. Physical activity of at least 150 minutes per week improves insulin sensitivity and reduces cardiovascular risk. Psychosocial care is essential and includes screening for depression, anxiety, and diabetes distress. Continuous glucose monitoring measures interstitial glucose every 5 minutes and provides time in range and glucose variability. HbA1c reflects average glucose over 2 to 3 months and is checked every 3 to 6 months depending on control. Most adults are targeted to HbA1c below 7%, while individualized goals range from 6.5 to 8.5%. Type 1 diabetes requires physiologic insulin replacement with basal and prandial insulin therapy. Rapid-acting insulin analogs like Lispro and Aspart are injected before meals to control postprandial glucose. Basal insulin such as Glargine and Degludec provide steady background control and reduce nocturnal hypoglycemia. Total daily insulin requirement is typically 0.4 to 1.0 units per kilogram per day split between basal and bolus doses. Insulin pumps and automated delivery systems improve time and range, but require strict monitoring to avoid diabetic ketoacidosis. Type 2 diabetes management begins with metformin, which reduces hepatic glucose production and is weight neutral. SGLT2 inhibitors reduce cardiovascular and renal events, but may cause genital infections and euglycemic diabetic ketoacidosis. GLP-1 receptor agonists improve glycemic control, promote weight loss, and reduce cardiovascular events. Sulfonylureas and other secretagogues are effective, but increase risk of hypoglycemia and weight gain. Insulin therapy in type 2 diabetes is indicated in severe hyperglycemia, catabolic states, or during acute illness. Diabetic ketoacidosis presents with hyperglycemia, ketones, metabolic acidosis, Kussmaul breathing, and abdominal pain. DKA management includes intravenous fluids, insulin infusion at 0.1 units per kilogram per hour, and electrolyte correction. Hyperglycemic hyperosmolar state shows extreme hyperglycemia above 1,000 milligrams per deciliter, with severe dehydration and altered mental status. Management of HHS focuses on aggressive fluid resuscitation, followed by insulin infusion and gradual correction of hyperosmolality. Inpatient glucose targets range from 140 to 180 milligrams per deciliter in most hospitalized patients. Special situations include steroid-induced hyperglycemia, total parenteral nutrition, and older adults requiring individualized targets. The key takeaway is that diabetes management requires lifelong individualized care combining lifestyle, medications, monitoring, and complication prevention.